Welcome back to another video from the Student Nursing channel. My name is John, and today we're doing an ATE assessment handover for the ICU. So during my clinical rotation at the ICU, we were given this guide on how to provide an ATE assessment handover for another nurse at the end of the shift or midway through a shift. So this allows us to do a much more systematic approach when giving a handover, so it ensures that we don't leave anything out that is quite vital when handing over. So I'm going to put here on the right side that piece of paper because I can't actually show you. I mean, I can try. Let's give it a try. Don't know if you can actually see it. It's not really that clear, but I'll put it right here on the right side of my screen, and we're going to go ahead and break it down to two different parts. So initially there's three main parts really. So the first part, which is in the top, is the patient's name and their diagnosis, so why they're at the ICU, followed by date of birth, hospital number, who they're under, as in consultant wise, or which registrar, which attending, so on and so forth, like which doctor is in charge of that patient. Lastly, if there's any relevant past medical history, as well as any allergies that the patient might have. So that is the initial part of the handover. Just make sure that you do have the right patient that you're talking about. That's what is important. The second part, which isn't really involved there, it's more of at the bottom of the screen itself, is the plan. So patient's understanding and awareness of the disease or condition they have. Next of kin, so whether that next of kin's been contacted, updated, or has just been notified about anything that's been happening. And lastly, it's just specialist team involvement, so whether that's the surgical, gynecology, medical, ICU staff, whatever their input is on the matter at hand. So with that said, from what I experienced when I did my clinical rotation, we had a system on the computer where we were able to assess what the doctors want, both medical, surgical, and ICU team, and what their outcome wants to be. So what we did was we kind of passed that over to the next nurses, saying this is what the plan is for them, this is what's already been done, and this is what we recommend you guys doing or trying to achieve at the end of your shift, on the nursing point of view. And we've also updated them what the surgical team, medical, or ICU wants, and what they wish to receive at the end of their shift. So that's pretty much like the second part itself. It's just an update on the plan, on the patient's situation and the interventions that they may have. And then the last part really is the actual ATE assessment itself. So obviously A is airway, B is breathing, C is circulation, D is disability, and E is fixed exposure. You'll see it all here in the screen itself. So one is A. So if you're in ICU, you're most likely to have a level 2 to level 3 patient, which is a high, which normally has a higher chance of having artificial airway, whether that's an ET tube, a tracheostomy, or just any other type of system, or ventilation wise. So you pass that over. So whether the patient has an ET tube, you pass it on. What size is it? The depth of it, so the measurement and everything, and why they have an ET tube. And this is quite important for all these systems, is what is the outcome? What is your aim at the end of the shift, end of the day, whatever. So that's your A. So breathing wise is followed by your O2 requirement. So obviously if their saturation is low or high, depending on what they need. Followed by CPAP or NIV, so ventilation machine, or NIV, which is non-invasive ventilation. Whether they do have it or not, and what are the options and what are the modes that is assigned specifically for that patient, whether it's spontaneous, whether it's assisted. And my light just went off. But yeah, so all that's quite important, making sure that the patient itself is looked after by the nurse in charge who knows exactly what's going on with the machines. Another one would then just be looking at the ABG, see how the saturations and those oxygen consumptions, because that will be shown on the ABG form or the chart itself. Any more X-ray results, air entry, secretions, drains, you kind of include that as well. And lastly, of course, you want to do a chest auscultation, seeing if the bilateral sound, equal sound, if you can hear any sounds at the base, whether it's loud, quiet, crackles, and all of that. So you've got to make sure you touch up on your auscultations. It'll be a great help when doing so. And lastly, of course, is the aim. What is your breathing airway or breathing plan that you wish to achieve at the end of the shift. So another one would be circulation, so C. So here we're talking about heart rate and rhythm itself. So whether the sinus tachycardia or just sinus rhythm, what their heart rate is, are they tachycardic, bradycardic, or normal. You would then do a cap refill. So obviously press down on one of the fingertips for 5 seconds, and obviously if it's less than 2 seconds, the redness comes back. Then perfusion throughout the body is quite good. Just having a look at the form itself, because I've completely forgotten, I haven't done it in a while. So inotropes, so you're looking at the values, whether they need to be topped up on magnesiums or potassium, any of that. Obviously you'll see it there. You got UDCO, TOD. I'm not going to go into details for that. You can research that if you want. Temperature, of course, whether they're spiking a fever or they're apyrexial, which says a lot of things about a patient, whether they're they've got an infection, because it's one of the first biomarkers to normalize this as well. So you'll be looking at white cell counts as well, CRP, blood samples itself, or the blood results. Just having a look at it, whether they're normal values or any of them are elevated. So you would then pass that down to the nurse, so that way they can do an intervention on their shift. Another one, of course, is definitely for circulation, which a lot of people actually do miss out, is urine output. Personally, I've missed it out so many times, but I've gotten to the point where I've got it so into my mind that urine output. It's such a vital result that you need to look into when looking how well a patient is. And obviously fluids, whether they're receiving any fluids or they're not, or they're waiting. And lastly, it's the aim. What is your aim regarding the circulation of the patient? Another one would be disability then. So this focuses more on the neurological status. So GCS, whether they're alert, confused, how is their muscular their neurology, or how their neuros are working and everything. So you can do your GCS test there. You can do your pupil test and everything as well. Are they in any sedation? Are they receiving regular pain relief? If not, are they on any PRN? Do they also have any muscle paralysis, which you need to be aware of when handing over? Also, their blood sugar. That's sweating. Blood sugar is quite important as well, whether they're hypo or hyperglycemic or they're normal. You want to focus on that, especially if they're type diabetic. And obviously the aim as well. So for E, we're looking at exposure / examination head to toe. So this is where you do your head to toe assessment. It's quite nice if you kind of get into a routine whenever you get a patient, you kind of just do a head to toe straight away and you do an A to E at the same time. That might not always happen, but you just kind of remember to do either an A to E first or a head to toe, and then a head to toe, or a head to toe, then A to E. Recommend doing an A to E. It's the fastest way to get a thorough examination of the patient. So here we're looking at infections. Is the patient spiking any biomarkers that can raise an infection? Are they scoring any scores on the new score that may lead or may seem like it's causing an infection in the body? Another one is obviously a CT scan, MRI, or other interventions. You just want to pass that on, whether they've already received one or are going for another one. And obviously you want to follow up with the doctors on what the result is, just so you can have an idea on what the situation is with regards to the CT scan, the MRI. Wounds and drains. Now in the ICU, depending what type of ICU is, whether it's a surgical or a medical or both, you will have a lot of drains, whether it's chest drains, pigtails, Robinson's drains. So you need to be aware where they are, when they were inserted, and how to kind of care for those, and whether you're recording the output, which you normally would be. So that's with the drains. PAC. Now, I completely forgot what PAC is, but I'll try and put that here as well. Anyways, also, and so for this also, it's just the medications that they're under. So if they have any regular medications, whether antibiotics or just heparin, for blood clots, anything that they normally would take, you kind of just pass it on as well. Nutrition, depending on what type of patient you have, they will require nutrition recording chart, whether you give them a TPN through straight to their bloodstream, or you kind of just have to assess and document what they've eaten, what they haven't eaten, whether that's fluids or food intake. Another one would then just be bowels. Have they been passing bowels, and if so, what type? You can also have an auscultation of the abdominal. If you hear any sounds, and it's good, we're not too concerned. You can palpate whether there's any lumps or consolidations, and there I recommend just passing it on to the doctors. And special considerations, now that would just depend on the situation. I'm not going to go into specifics on what special conditions will be. And lastly, obviously, is the aim. What do you guys aim for when treating for a patient on the exposure side, just like with any of them? But so this is just the basis guideline that I normally use when doing a handover or even receiving a handover of an ICU patient. Hopefully you guys find it useful, and hopefully I'll make another video soon.